Hi Ninja Nerds, in this video we're going to talk about chest tubes. If you like this video, please comment, subscribe, let's get into it. First Ninja Nerds, let's talk about where the chest tube goes. We're going to place the chest tube in the pleural space, and the goal of it is to remove fluid, blood, air, and pus within the pleural space cavity. You're probably thinking, well, what the heck's the pleural space, or I forget what that is. So we're going to go through this diagram real quick, identify some key anatomy pieces that we need to know in order to understand what's going on with the chest tube. First thing here is this big orange piece coming down the middle, and that is our trachea. What is our trachea? What's the important role of the trachea? The trachea, remember, is the windpipe, or is the way we bring in oxygen and expel out CO2. On the side here, we have number 2. It's identifying these little, look like white ovals, which is our ribs. And our ribs are allowing our lungs and all of our vital organs within our rib cage to have protection. And then we have right here our intercostal muscles, which are these red little blobs right between all of our ribs. They are helping us facilitate breathing to expand and contract with our breath. Underneath here, we have this big, long, red muscle. You guys know what that is, right? It's the diaphragm. And our diaphragm is also a very important muscle to facilitate breathing. We've talked about the breathing component, but let's talk about what's going on inside the lung space, the most important layers right here. So the first thing we have is this pink layer, right? What is that? This pink layer here is called our visceral pleura. What is our visceral pleura? Our visceral pleura is that lining outside of our lung that's connecting to our lung tissue. Then we have this dark blue lining here. What is that? That is our parietal pleura. And what is the parietal pleura? The parietal pleura is the layer of tissue that is connecting to the chest wall. So it's allowing for the visceral pleura to expand into the parietal pleura. And there's a space in between there, and we're going to call that the pleural space, which is the most important part right now of chest tubes and why we're going to talk about chest tubes. The pleural space. So you're noticing on here versus here, it's a lot bigger, right? It's really nice and tight. The visceral pleura is expanded into the parietal pleura. It's filling that area, but here it's not. Why? In the medical field, we have different terms to explain some of the things that can be found in that pleural space and what's going on. First one here is a pneumothorax. Pneumothorax is typically air that is found within the pleural space that shouldn't be there. There shouldn't be this space. There shouldn't be this compression on the lung and making the lung push up into a small ball where we can't take a nice deep breath in, right? So one of those things could be air. The next thing could be a pleural effusion. What's a pleural effusion? Pleural effusion is typically some type of fluid that is located around the lung, again, in that pleural space. The next here, notice the color. It's a darker brown color, browny red color. This is our blood. A hemothorax is blood. Blood that is found within this space. And the last thing is one of my personal favorites, a pulmonary empyema, or when we find pus in the pleural space, typically when that fluid becomes infectious. So we're talking about these different types of things that be found in the pleural space, and we're going to be putting in a chest tube for them. Now, let's defer real quick to these two different types of fluid, air, pus, liquid, blood that can be found within the pleural space. They're divided into two different areas of chest tube placement. The first is air. Air is typically found at the top. So if you have a patient that has a compressed lung that's pushing down, this air is pushing down, compressing that lung, we're going to be placing a chest tube up here to allow that air to release. Okay? And then if we need to place a chest tube for fluid, blood, or pus, typically that's going to be through the bottom here. Why? Why are we placing air at the top and something for blood, pus, and fluid at the bottom? That's because this is a very dependent area of the lung, correct? We're walking around. It's where the blood likes to settle. It's like the fluid likes to settle. So to release and get all that out, we're going to put a chest tube in the lower portion of the lung or the pleural space in order to get it out. What is the goal? Why are we putting in a chest tube? It's to facilitate the lung expansion. Remember, our chest right now is not being filled with air. This lung, this pleural space is being compressed. So we're not able to take a deep breath in. We're not able to fill our lung completely. So we have this compression, and we want to take that out so that we're able to expand our lung correctly. So your patient is not able to expand to that space. What's going on with them? So we have a patient that's got this compressed lung. We're pretty sure of it, but we want to get some signs and symptoms on them. So what are some things that are going to be shown by our patient that they may have a compressed lung? The first thing is going to be shortness of breath or dyspnea. And what does this word mean? Difficulty breathing. So they're having difficulty taking a deep breath in or getting air into the lung, right? Because it's not expanding, it's not filling into that pleural space. What are other things they're going to have trouble with? You're going to be listening to their lungs, right? You're listening to their lung sounds. And what are you going to hear on that affected side? You're going to hear a diminished or absent lung sound, right? Why? Why is that? It's because there's compression, again, on this lung that's not filling in. So if you're listening down below and it's not expanding to that area, you may have no sound. What else is going on? They may have some, what we call pleuritic chest pain. But at this time when you're assessing your patient, you're not quite sure. Is it pleuritic? Is it chest pain because it's cardiac? So we're going to make sure we notify that they have chest pain. Ask them what it is, how did it start, how does it occur. What else might this patient have? They're having trouble breathing, they're having trouble taking a deep breath in. Typically, because of that, they have a dry cough. What does that mean? It's not going to be productive. They're not going to be having mucus, they're not going to have a lot of secretions. What they're going to have is a dry cough, something that's just kind of irritating, really making them cough often, especially when they try to do something that's exertion. And then the last thing they're going to have is you're going to see right here, you see this blue vein right there. That is a distended neck vein. And why would they have a distended neck vein? We know as Ninja Nerds that the cardiac and the pleural circulation is connected. And when there's an issue with the pleural side or there's something backing up on that affected side, they may have a distended neck vein. So on this person, they may have a distended neck vein right here, right on their neck. So you're going to take a look at that and say, all right, they got all these signs and symptoms. I think they might need a chest tube. The last thing is the doc is probably going to get a chest x-ray. It's going to show clearly that there is a compression somewhere on either lung. And then they're going to say, let's put a chest tube in. As a nurse, we're going to get some things set up before the tube is placed. So you want to make sure the first thing is consent signed? You're not getting consent signed. You're going to say, hey, was consent signed? Remember, as a nurse, it's just your job to make sure it's signed. You're not getting it signed, and you just want to make sure the patient understands what's going on. Next is going to be allergies. Do they have any allergies to any medications? They are getting a procedure that requires them to have consent. So you want to make sure they're not having any allergies to any of the equipment we're using or the medications we're possibly going to be giving them. Next up is going to be position. We're putting in a chest tube, so typically we want them to be in the supine or the semi-Fowler's position. And that's one they always like to hit on the NCLEX, so make sure you know that. Medications. What are we going to be giving a patient before a procedure? Typically it's going to be some type of pain medication or sedation. You want to make sure they're comfortable during this procedure. You want to make sure that they're able to get through it without having too much excruciating pain. Then you want to make sure you get the chest tube and set it up, and you have an order from the physician for a water seal. This is most important. You want to make sure you have the correct type of chest tube to get set up, and then you're going to set up the chest tube for the patient. We're going to set up the chest tube now. So you probably have never seen a chest tube atrium before. If you haven't, that's fine. I'm going to walk you through it. This is typically what they always look like. We're going to just identify some structures on the chest tube so you get a little understanding of what's going on and what you should be looking at as the nurse. First, let's just look right here. This is the tube that's going to be connected to our patient. And most important part about it is the ending, which I'll just draw what it kind of looks like here. Typically, it's like this little point that's going to be attaching to our chest tube that's within the patient. So the most important thing is to remember that this portion needs to be sterile. So when you open up the chest tube, this is packaged on the back, And when you take everything out, this doesn't need to be sterile. Nothing else in here really needs to be sterile at all, except for that portion that's going to connect to the patient. So we got that figured out. We take the chest tube out. We're looking at it. We're making sure some things are correct. We don't see any breakages or anything like that. You want to make sure all these connection pieces are just connected really nicely, so when we put the chest tube in and set it up, it is working properly. There's going to be a little water bullet on the back of the chest tube. You're just going to take that and you're going to squirt that into here, and you're going to say, squirting it into there, where's it going to show up? You're going to look down here, and this is our air leak and our water seal window, okay? So this is typically where you're going to be looking. This is where the NCLEX is going to ask all its questions, and this is where you're going to monitor your patient along with their drainage and output, which we'll talk about in a second. This is our water seal and air leak chamber. What we're looking at here is when we put that water in, this ball was originally blue. It dyes all this water blue and becomes a white ball, so it's a lot easier to see what's going on here in the water seal chamber. The water seal should only have intermittent bubbling. It shouldn't have continuous bubbling, so just keep an eye on that. When you first put the chest tube in, there will be some bubbling in this water seal or in the air leak. That's okay. Just make sure you're monitoring it and it's not getting any worse. Over here is our collection chamber. So you're going to see here the collection. And this is where we're going to be monitoring our output, right? So you're going to attach that chest tube to the patient finally, and we're going to have stuff come in through the collection chamber and start filling up here, which is ideal. The other thing you want to check is you want to make sure that right here, this is our suction control. Our suction control has a little orange indicator that is set to -20. This is just to make sure that we are keeping a nice positive and negative air pressure system within our lung in that pleural space. So this is just going to help control with that. Now, if it's not a water seal setup, then you need to pay attention to this window here, which is our bellows, along with your vacuum pressure. On the back of the chest tubes, they will indicate typically what the wall suction should be. On the ones that I'm accustomed to, it'll say -80 milligrade of mercury. So you're just going to set your vacuum to that. Go whatever what the provider says. So if it's continuous or intermittent, typically it's always continuous, but whatever the provider wants. And you're going to go from where we had originally put that water in, you're going to take your suction tubing and you're just going to connect it to your wall suction. When you do that, this bellows will pop out. This is only for if you're connecting to wall suction will the bellows pop out. If there's no wall suction, nothing to worry about here, but it's just this little orange indicator to make sure it's coming out here to this little arrow, and that's going to make sure that this whole negative and positive air pressure within this body is normal, okay? So everything's working properly. It's just an indicator for us. Let's recap really quick what's going on here with our atrium. Remember, we have this sterile end that's now connected to the chest tube of the patient and is coming into our collection chamber, which is draining all of that fluid, blood, or pus into our atrium, which we're going to be able to monitor. We're going to be watching over here our air leak and water seal for any type of bubbling that has changed. And we also have our suction control up here. And just remember, the chest tube also is just placed on the floor below the patient's chest. So there is a handle here in case we need to move it or walk to the bathroom. They can just hold it right at their side. And underneath here is a little pivot device that you just, when you open up the whole system, it just swivels out. So it's really nice. So you can just place the chest tube right on the floor when they're in bed or in the chair. So we have this all set up. We're ready. We're waiting for the provider, and we're just holding basically the tube right here with a nice sterile end that's not being contaminated. So during the procedure, in the interim, what we're going to be doing is we're just going to be assisting, which again, we have set all this up. That's part of the assist. We're monitoring the vital signs and the sedation, making sure the patient isn't showing any indication of distress or pain. And we're just going to be handing over that sterile end to the provider. So as they make that incision and insert the chest tube, when they're ready, you can just hand that to them and they're going to attach it to the chest tube. One important tip when you're monitoring the patient, you're making sure the sedation's good, making sure their vital signs good, so you want to keep an eye on their hands. So patients that are sedated still feel pain sometimes or still are reacting to what's going on around them, and they may just start reaching and grabbing, or they may contaminate that sterile field. So you want to make sure that you just keep an eye on their hands because that's really important. You don't want them to start pulling on things that shouldn't be pulled on. Once the provider has inserted the chest tube, placed their sutures, They are all done, and we're going to move into post-procedure, which is basically us monitoring the chest tube and keeping an eye on the patient as well. Now that the chest tube is in, let's go in to talk about how we're going to be monitoring and keeping an eye on our patient. Immediately, once we have placed the chest tube, especially if it's going to be placed for the fluid, blood, or pus, there should be return within our collection chamber. But just to make sure, the provider typically may want to get an x-ray to make sure that the chest tube is in the pleural space and doing what it needs to do. Once that chest tube is in, the x-ray, they say it's all good, everything looks good, we're going to go through and make sure we're checking their vital signs. Particularly, we want to check their respiratory rate and their lung sounds, right? So we want to listen to them. Why? Why is that important? Well, we originally listened to them and there was diminished or absent lung sounds on that side. Now there might be a little more of an increase, and this is something to pay attention at shift change. Make sure you're understanding what's going on with the patient, how have their lungs been sounding. We also want to keep an eye on their oxygen saturation. Remember, they're O2. We want to make sure that they are getting better. Everything's getting better with this patient, not getting worse. We're going to be monitoring their cough, right? And we want to make sure that we encourage deep breathing, right? Or a deep breath in. This is because that lung is now going to have space to fill in because that pleural space is getting evacuated. So we're taking things out so that lung is going to be able to expand better. So we want to encourage them to be taking nice deep breaths in. One of those things we can also encourage them with is the incentive spirometer, okay? This is something you might want to do after a couple hours of the chest tube being in, allowing them to start seeing if their lung is expanding. Is their breath getting better? Is their breathing getting better? We're placing that chest tube, and we want to make sure that while we're placing it, we're going to be documenting the color and the amount of the drainage or the things that we're collecting in the atrium. Typically, once it is placed, the first 8 hours, you're going to do it every hour. So for the first 8 hours of placement, every hour you're going to go in that room, you're going to see how much, you're going to document the color, you're going to document the amount. That way we're able to tell, is it getting better, is it getting less, do we need to remove the chest tube? Because that's the whole goal, is once the tube's in, we want to get it out. After those initial 8 hours, it's going to be every 8 hours. So remember, it's Q 1 hour for the first 8 hours, and then every 8 hours after. How are you going to do that? You're going to document your color and your amount. You can do it right on the atrium. So say at the end of your first hour, they got 200, right? So you just would take a permanent marker, or you can take whatever your facility uses, tape, mark it here, put the time. So we'll say it was at 2100 or 9 p.m. They had 200 out, and you're going to mark it within the documentation of your facility, whether it's the computer or writing it down. You're also going to assess the site. Make sure the site looks good, right? So assessing for any type of drainage, redness, okay, or any type of leaks at the site as well. So you hear sounds or anything that's coming out that shouldn't be. You also want to make sure when you're monitoring the patient, you're also monitoring the chest tube and the atrium. Within the water seal, you want to make sure that there is still enough fluid. If there's not, if it looks like it's starting to evaporate out, because it will if the chest tube's in for a couple of days, you just want to add more water to the water seal chamber so we're able to keep an eye on that. You want to make sure you're also documenting if there's any type of bubbling that's going on or any changes within the patient. And the last thing is titling. You're going to say, what the heck is titling? What's going on? So titling is when the ball within the chamber goes up and down with breathing, and that's normal, okay? So when the ball in that water seal chamber is going up and down, that means that there's a lung, right, that's going up and down with breathing. That's fine. The idea, though, is did it stop or no titling? If the titling has stopped, that means our lung has expanded, and that means that we don't need a chest tube anymore. So if you walked in and you're like, yo, titling's not going, let me make sure you tap on the little spot where the ball is, make sure the ball's not just stuck there, and you see that titling has stopped, then you know, hey, I should probably contact the provider, get a chest x-ray, because we can probably take this chest tube out today, which the patient is always excited about. What do we need to keep at bedside? So the NCLEX is going to ask a lot about monitoring, but it's also going to ask about what you should have at the bedside. And these are things that you're going to need if there's an emergency, that if something happened to the chest tube, we are able to fix it immediately and we are able to protect our patient. And now we're going to talk about what you need to keep at the bedside. This is just something that the NCLEX likes to hit on, but it's also something that you want to make sure you have when you set up your chest tube. Typically what I do is when I grab this chest tube, I just grab all this stuff right away so I have it at bedside, so that way I don't have to leave the patient again to get those things. So I go in the supply closet, and these are things that I grab. The first is H2O, particularly a sterile container, right? And you're gonna be like, why? Why do we need this sterile container of H2O? And that is because if there is some sort of dislodgement of the atrium from the chest tube, and you walk in and your patient just has a tube sticking out of their rib, you're like, what's going on? You can create a water seal by just taking the end of the tube and dunking that water right there. So that's able to create a new water seal until you get another atrium. Hopefully, though, you already have another atrium at bedside, right? And you're able just to put that chest tube right on. All you're going to do is disconnect it, attach it, and then you're going to be able to have this patient be fine. Then note all this in your documentation. There was a leakage, there was something that fell out, things like that. And the last would be this 3-sided gauze. All right, this is just in case everything came out and your patient has a gaping wound on the outside of their body. Also bring this along when you transport a patient. It's a lot better just to put a little bottle of H2O or a 3-sided gauze on the outside just in case something were to happen during transport. We're monitoring our chest tube and we want to make sure that there are some things that we're prepared for in case a problem happens. There will be a problem. You're going to run into a patient, hopefully never in your career, but probably at least once in your career, where something happens with the chest tube and you're like, uh-oh, I need to fix this. I need to remember. And these are the things that the NCLEX likes to hit on, those rare occasions. What are you going to do? How are you going to react? The first thing is if there's an air leak. How are you going to know if there's an air leak in your chest tube? Most important thing here is that continuous, right? Continuous bubbling in the water seal. So we have that water seal, we have that chamber that we're able to monitor for air leaks. Right there on the atrium. You're just going to look in that corner. You're going to say, there's continuous bubbling in there. There might be an air leak. Then what are you going to do? You're going to check all your connections. What does that mean? So you're going to check these connections and you're going to make sure that there is no leaks coming out. You're going to say, how do I do that? Real easy. The way I like to do it is I just go from the patient, I look at their site, I make sure there's nothing going on right at the site of the insertion of the chest tube, and then I trace my tubing, I trace that chest tube all the way down to the collection chamber, checking all those connections, making sure they're nice and tight, making sure there's no leakage coming from them. Sometimes the chest tubes get cracked, especially if they're in for a couple days, or they start to separate, and so you want to make sure you just pull them back together, push them back together. If you're not able to fix the air leak, or you notice that the air leak is coming within the atrium, then you want to let the provider know so we can change everything out. The next is going to be a disconnected, breakage, or an accidental removal. So we have, again, with the NCLEX, they like us to keep these certain things at bedside, so when they ask that question. The first thing, again, is that sterile water, right? We want to make sure that that sterile water is at bedside. Why? That's in case there's a disconnection. When you walk in, all of a sudden you see the patient is standing there and there's a tube in their body, but there is nothing connected to that tube. The tube's just hanging out. It's just right there. You're going to take the end of that tube and you're going to dunk it into a sterile container of H2O. And that is to make sure that we recreate a water seal. What's that water seal for? Why are we doing that? We're doing that so that the patient isn't starting to give themselves a tension pneumo by breathing in that air into that pleural space, and now all of a sudden we have another problem. Is there a breakage? So we're always going to have a second atrium at bedside, right? Just in case we have a breakage. So something happened, someone knocked this over, someone bumped this, someone hit this, it got cracked, there's a break somewhere, or it's totally full, and we need to change it. We're going to put that second atrium on, just going to disconnect and reconnect right from that nice little connection point. And the last thing is our sterile gauze. So what we're looking at here is for our sterile gauze, 3-sided. So we have 1, 2, 3 sides of tape, and then this side open, which is a flap. And we use this in case the patient has completely removed their chest tube and they just have this gaping open wound here. What we're going to do is we're going to take that and put that right over. So when they exhale, it's going to release that air out, but when they inhale, they're not going to pull air into that pleural space. Good thing is if the patient is up for removal soon and they accidentally remove it themselves, there may be a point where you can just put on a better dressing and move from there. The last thing is a tension pneumo. I mentioned this before. A tension pneumo is caused typically by a prolonged blockage, a clamp, or an obstruction. Within the chest tube, when you go in the room and you see the water seal, there's no leakage or bubbling, and you notice that there's no titling. The titling isn't going anywhere. Usually it's an indication of a healthy lung, but there is sometimes where there is a clamp or a blockage or an obstruction. So think about this. You have this long tube that you're supposed to be expelling out something from the body, and it's blocked or it's clogged or it's kinked because it's not laying nice and straight on the bed. And we have created an tension pneumo. What does that mean? A tension pneumo is when there's so much pleural space taken up by air that it's literally pushing on the heart and pushing on the trachea and pushing everything over to that non-affected side. We have created a tension pneumo by that blockage or clamping or obstruction, and we'll have no lung sounds. We're going to have decreased O2 because we have only one lung we're working out of. They may be in respiratory distress. They may have cyanosis depending on how long it's been going. And the number one sign is they may have that tracheal deviation. Remember from the beginning of the video, we talked about orientation of what are some of our important components of body anatomy. And one of those is that trachea all of a sudden is getting pushed to that side, to the non-affected side. Because of this, we need to immediately respond. And one of those things you can do is call the healthcare provider or call a rapid response and say, hey, I got a patient in here and I need your help now because we got a tension pneumo. I have no breath sounds. They are decompensating quickly. We need immediate intervention. So tension pneumo is the most important and most traumatic thing that can happen if there's a blockage, a clamp, or an obstruction within our chest tube. Now, everything goes smooth. Our patient's lung is expanded. Hooray, there's no more titling, and we are able to take this chest tube out. What are we going to be doing? We are going to remove the chest tube, and just like pre-procedure, in this part, we're going to make sure we have medications again at bedside. Typically now, all we need is pain medication. We don't need anything else because the patient, once it's removed pretty quickly, they're going to feel a lot better. The other thing we're going to need is a suture removal kit. You can always grab that or the provider will bring it at bedside. And that's just to remove that tiny little suture that's right, maybe there's two, right at the insertion site so that we can take that tube out. So when we do this, when we're ready to take out the chest tube, you're going to tell the patient to take a nice deep breath in and bear down. When we do that, it's to create that closed pressure system within the lung cavity, and it's called a very specific, it's called a valve maneuver, okay? So you're going to tell them, take a deep breath in and bear down and hold on to it. That's going to allow us to take that chest tube out and apply the dressing immediately so that we don't have any type of tension pneumo occurring or any other air going into that pleural space. So they Valsalva, we apply the dressing. We're going to be putting on a petroleum sterile dressing. So a little different than the three-sided flap dressing. This is going to be a sterile petroleum that's going to allow them to kind of that close off because now we have a healthy lung. We don't want any movement anymore in there. Moving on to our thing right here, this is the most important thing that the NCLEX likes to hit on with chest tubes. Never milk, strip, or clamp the chest tube. Remember, a tension pneumo is created when you do some type of clamping or occlusion or a blockage within that tubing system. So that's why the NCLEX tip is to never, if there's a choice that says clamp, milk, or strip the chest tube, don't pick it. It's not the right answer. Remember, continuous bubbling in the water seal. If there is bubbling in that water seal, there's an air leak somewhere, and we want to make sure we're checking on it, and we do the immediate interventions that are going to help us with this. So remember, this is not good. And the last thing is bright red blood. Remember when we talked about hemothorax in the beginning, it's a more rich, dark, old blood color. If there's bright red blood, that's a sign that something is wrong. If there's something traumatic going on, that there's an active bleed somewhere, and we need to tell the provider immediately, especially if all of a sudden the chest tube's been in, maybe say 6 to 8 hours, and all of a sudden there's now bright red blood and it's over 100 milliliters an hour. You want to make sure you're telling the provider because this is a sign that there's something serious going wrong. Thank you, Ninja Nerds, for getting through this video. I hope it made sense. I hope you enjoyed it. And if you like it, please give us a thumbs up. As always, until next time.